Um, so historically, DSM has stated that the personality disorders are characterized as enduring patterns of inner experience and behavior that are maladaptive, and ironically, they say present since early life and persisting into adulthood. So even though the historical definition of personality disorder acknowledged that in many cases symptoms would be picked up in childhood or adolescence, it still prohibited the diagnosis or the assignment of a personality disorder diagnosis if the individual was less than 18 years old. This has actually changed in DSM-4 and DSM-5. It will allow for a diagnosis of personality disorder under the age of 18. However, decades of DSM dogma on this has a, I think, enduring effect on prescribing culture and on diagnostic culture. I mean, to their credit, would be, well, I think to the rationale of not assigning a diagnosis of personality disorder to a, say, 16-year-old, we acknowledge that during adolescence there can be a lot of shifting of moods, and impulsivity can be higher, and so standards of behavior that we would apply to a 30-year-old shouldn't be applied to a 16-year-old. So that's, I mean, it's a worthwhile rationale. Yet on the other hand, critics would say that that turning a blind eye to the possibility of a personality disorder diagnosis in an adolescent, that it can produce some harms, and I'll explain those harms during those possible harms during this talk. But actually, bullet point number 3 does address one of these harms, in that if there is a cultural bias toward assigning Axis 1 diagnosis, where Axis 2, so-called personality disorder, is probably better explains things, then we do two immediate great harms to the individual. Number one, we focus on a diagnosis that is quote-unquote Axis 1 that might not actually be there, or if it is there, it will respond very poorly to standard treatments for that diagnosis. So we will, there's a risk that we push the individual into round after round of pharmacotherapy. Initial rounds probably will be unsuccessful, which will easily lead into what I would call creative pharmacotherapy. And I say that kind of euphemistically. The other potential immediate harm of ignoring an Axis 2 condition is that we put aside our obligation. Well, many clinicians have the idea that we have a moral duty to give patients accurate information. There are some exceptions. There's a line of reasoning to say that we should give people information that they're able to hear and for a greater good. So I would call that a more paternalistic view. Doctor knows best, and I'll let you know what you need to know so that you can, have a trajectory that I imagine you should achieve. I think that that's a minority view in medicine these days, and the majority of clinicians will say that patients have a right to know everything that we know, in terms that they can understand, of course. So if there is suspicion that something like antisocial personality, borderline personality, histrionic personality disorder symptoms are there, but we don't call it that, then we're denying patients and their families the opportunity to seek out treatments which would be more appropriate for the Axis 2 condition, and denying the patients and the families the opportunity to think about this illness and its prognosis and its implications for life management and treatment. For those who remember my last talk on this topic of related personality disorder, I have a hard time containing my contempt for the DSM and the American Psychiatric Association enterprise for calling these family of illnesses that affect mood, thought, and behavior personality disorders. There are some benefits or some rationale for coming up with this diagnostic term. So the metaphor is understandable to explain something that's relatively enduring and that may be rooted in or associated with how one perceives, interprets the world and themselves in the world. And so these constructs, come close to elements of personality. So it does make some sense to view these enduring illnesses as related to or affecting or generated from aberrant belief systems, which debatably can be called part of personality. And again, my contempt is already showing, it pseudo explains medication non-response. So, historically, in behind the scenes politics of personality disorders were such that now we've discovered antidepressants and antipsychotics and antimanic drugs. So we'll call depression, schizophrenia, and bipolar disorder axis 1. The belief was, and actually this was stated flat out in some earlier DSMs, that these are primarily or heavily influenced by aberrant neurochemistry. And essentially the cut was axis 1 are things that we can treat with medicine, and axis 2 we can't. But so if you have this construct or this pseudo theory that said, well, no, okay, it's a theory. If you have this theory that says that something like borderline personality behaviors and experiences are related to personality, then that explains why medications don't work. A mentor from way back in my professional childhood told me one time. He was a psychoanalyst by training, and so he was historically very biased against medications and neurochemistry. And he told, and he obviously had the belief that intellect, mind, and personality things are of primary importance. And he said, just think about this: will you ever be able to get a medicine that will change a person from Democrat to Republican, or from Christian to Jew, or whatever else? The point was that there are certain things that are beliefs, and only other information or experience will change beliefs. You can't through chemistry change belief systems. So there's that little pearl for all of you. So there are some rationales or potential benefits to the personality disorder construct. There are some extreme harms. First of all, person is a root word of personality. So when you tell somebody you have a personality disorder, you're easily going to be heard of, you have a disorder of person, which is of all the terms that a professional society could have chosen, to stick with the one, to identify the one that is based around person, and to let that run for decades, it borders on a crime against humanity. And why I say crime against humanity is because I see in every place I go examples of extreme therapeutic nihilism and negative transference, and all this with nearly zero empiric scientific evidence to support the idea that this is caused by personality. So there are, let's see if I have the slide. No. When the American Psychiatric Association decided to come up with the construct of personality disorders and taught the whole world that these disturbances of mood, thought, and behavior are caused by personality, then scientists like me who are interested in neurochemistry, neurocircuitry, neuromodulation, or things that would actually get to development of medicine, all my brethren just said, nah, personality, that's not what I'm into. So the biological scientists, the relatively small number of biological scientists who would be interested in understanding psychiatric things turned their attention to the things that we've been told are biological, the schizophrenia, bipolar, and so on. So biological scientists left in droves. And if you type in schizophrenia etiopathology in PubMed, you'll see literally 90,000 papers on that topic. If you type in borderline personality disorder, idiopathology in PubMed, you get about 500. So that really, it turned off scientific research, and led to a vicious circle where we haven't developed biologically based treatments because we were told it's not biology, and therefore we don't get the patients better very well. And because patients don't get better very well, and because people have been taught this is personality, then clinicians become pessimistic and negative toward the individuals. And this is very ironic because the DSM in other chapters or other writings claims to be atheoretical, to develop these criteria without consideration of etiology. We just want to go by things that are reliable. So it's very weird. I mean, it's actually unique that in a tome in a diagnostic system which claims to be atheoretical, we retain the notion of a personality disorder, which does strongly imply knowledge of cause. Another problem with this is that in addition to driving away biological scientists, insurance companies were all too happy to latch on to that. And the argument by insurance companies is we pay for medical diseases. We, the insurers, can understand that bipolar disorder should be a medical disease because U Psychiatry Association has told us that it's involving chemical imbalances, and so we're in to pay for that. But we don't pay for personality. I mean, we don't. If a person is a Democrat in a Republican stronghold and is miserable on account of nobody is like-minded, we're not going to pay for that kind of thing because that's a belief system. So because insurance companies would for decades deny payment for things like antisocial personality, borderline personality, histrionic personality, then we didn't develop a therapeutic infrastructure very well, and we didn't train clinicians very well because why specialize in the treatment of an Axis 2 condition if there's no money to pay for that service? And then it pushes people into overdiagnosing Axis 1 and minimizing or ignoring Axis 2. This I sort of already riffed on this slide, but this system has set up a vicious circle. So we don't diagnose Axis 2. We instead misdiagnose it as Axis 1 or pay attention to a bona fide Axis 1 condition. Like 80% of people with borderline personality will meet diagnostic criteria for either major depressive episodes, recurrent major depression, or what used to be called dysthymic disorder. So there is that for sure in any borderline person. But if we flip it around, if we look at the population of all people with depression who fail to respond to antidepressant therapy, the so-called treatment-resistant group, you'll find that between 50 and 80% of that population has a diagnosable Axis 2 condition, which usually is not recognized. So inadequate recognition of that leads to therapeutic failure. Nonetheless, if we give the wrong treatment, the patients don't get better. If the patients don't get better, they show up more often demanding that we make them better. And since we can't make them better because we're thinking about this wrong, they don't get better and they show up again. So this reinforces this culture of therapeutic nihilism and patient burnout on behalf of providers, and patients are not helped and neglected, and they get more angry, and then they show up again more angry, and so you have this cyclical dyadical cluster that isn't helping anybody. So we should be a lot more. Oh, that's the end of that. So we should be a lot more open to